Our next session will be about the preoperative management of cardiac patients. We will have 4 speakers, and we will start with a very interesting topic that we will all love to hear and hear again and again and again. ACLS guidelines update, which will be useful for all of us, especially for our trainees and Kuwaiti board resident. Please welcome Professor Gazmuri for the presentation. Already my colleagues did present Professor Gazmuri today, and he is practiced his critical care medicine for 2 years. Then he traveled to the US. He's currently a professor of medicine and physiology and biophysics at Rosalind Franklin University of Medicine. He served as a member of Basic Life Support and Advanced Cardiac Life Support subcommittees of American Heart Association. Please welcome Dr. Gomez.
Thank you so much for the kind introduction and for the opportunity to discuss this topic. It's working fine now?
Yeah, it's fine. What you need?
So I was asked to talk about the new guidelines for ACLS that were published back in 2015 and address mostly the updates of these guidelines. So what I wanted to first give you a little bit of overview of what typically happens when somebody has an episode of cardiac arrest outside the hospital. And I developed that slide, I would say probably 15 years ago, and I think we have improved, but not a lot. So essentially, I'll try this one. So if somebody has a cardiac arrest outside the hospital, sudden cardiac arrest, usually it's VF, but at the time in which somebody identified the rhythm, it could be pulses, electrical activity, or asystole. So shockable rhythm have decreased in terms of the percentage down to about 30% at the moment. So what would happen if we have an effective emergency medical system is that about 30% of those individuals are going to have return of spontaneous circulation, ROSC. That means there's a pulse. So there's no need to continue doing CPR. And this is the time in which the patient is going to be taken to a hospital. But en route, some of them are going to die from recurrent cardiac arrest. So we're now down to 25%. And getting to the hospital doesn't mean that the patient is going to survive. So ultimately, we're talking about roughly a 10% survival. So of 100 patients, 10 of them are going to survive. That's the bad news. The good news is that most of those who survive do it with adequate neurological function, and they can resume their previous activity. So plenty of opportunities to intervene. If we modify our lifestyle, we might be able to reduce the incidence of coronary artery disease, which is the main driver of sudden cardiac arrest in our population. And we have done that, I think, successfully to some extent. We can have better bystander CPR, better ways of providing CPR. I'm going to discuss that in a minute. And in the hospital, we can also impact the fate of these patients. Now, a brief word about what we do worldwide. There's an organization called the ILCOR. That stands for International Liaison Committee on Resuscitation. And that brings many councils together. You can see there American Heart Association, Inter-American Heart Foundation, Australian Resuscitation Council. So it's the aggregate of all these councils that form ILCOR. And ILCOR will come up with recommendations worldwide after reviewing the scientific evidence. That process has been done every 5 years. So the last one was issued in 2015, before it was 2010, then 2005. From now on, it's going to be a continuous process. So every time there's new evidence that something worked for cardiac resuscitation, there's going to be a new recommendation. So the idea that we would do it every 5 years is no longer. It will be done based on evidence. So that's what ILCOR does, and I wanted to show you this document here is called the COSTAR document. The way it works is, or it used to work, there will be a consensus on science and treatment recommendation for everybody. And then each council will adapt those recommendations to the local reality. So at the end, the guidelines might change a little bit from country to country based on what appeared to work better for that specific area in the world. All that from a big document that is consensus called the COSTAR document. And at the end, each council, in this case, for example, the American Heart Association is going to issue guidelines. And then we have guidelines from the European Resuscitation Council, and I'm sure you have your own guidelines and so forth. Now, if you want to read the American Heart, that is there, it's free. You can download the guidelines, and you can find everything that was discussed and recommended back in 2015. So that is free of charge. Now, I wanted to give you this slide here just to impact on you what happens when the heart goes into cardiac arrest. And I have two slides that looks at some of the work we did in our laboratory, but I wanted to show you what happens. But you see on the other, on top there, I don't think I have a pointer here, but you see this is a pig model of cardiac arrest in which we induce ventricular fibrillation. So before we induce cardiac arrest, you can see the electrocardiogram, that's a sign of rhythm. There is good blood flow through the coronary artery. That's the LAD flow. We put a probe in the left anterior descending artery, and that perfuses the heart. When the heart goes into VF, there's no longer blood flow. So I wanted you to realize that the heart still is consuming a lot of energy, evidenced by ventricular fibrillation. The heart is fibrillating, and there's no blood flow. That creates a severe imbalance between oxygen demands and oxygen requirement. And that is the reason why the heart very quickly is going to develop severe ischemia. In fact, you can see here, this is what we do when we do CPR. We artificially create coronary blood flow. And the more effective CPR is, the more coronary blood flow is generated, and that increases the likelihood that we're going to be successful in reestablishing cardiac activity. Now, in this particular experiment, we measured many things directly into the myocardium because we were simulating cardiac arrest using extracorporeal circulation, ECMO. And I want to show you the myocardial lactate. Let's see, we look in red, for example. That's a controlled animal. You can see the lactate going up to very high levels, even when we were simulating what would be conventional CPR. So the idea that CPR is going to end ischemia is not true. Ischemia persists. That's the reason why we want to resuscitate as soon as possible. And ischemia gets resolved only after there's return of spontaneous circulation. Now, in this particular experiment, we're using a pharmacological intervention to reduce the injury at the time of reperfusion, meaning at the time of CPR. That's the reason why in blue you see less increase in lactate. But that's not the purpose of my talk. I just wanted you to realize when the heart is fibrillating, it's creating very severe ischemia, and CPR is not enough to reverse that. We can mitigate, reduce a little bit the intensity of ischemia as we make the attempt to restore cardiac activity. Very importantly, this concept of the chain of survival is totally valid today as it was when it was first proposed. So what is important here, I just want to go you very quickly. One is the recognition of the event. There's no question that witness arrest have better outcome than the unwitnessed. So time is of essence here. So the recognition of the event, activation of the emergency medical services system, initiate high quality CPR. That is responsibility of the bystander. As the emergency service come to the place. Now, because 25-30% of the victims will have VF. The most effective treatment is to deliver an electrical shock. So early defibrillation is essential, and that's the reason why today we have AEDs, automatic external defibrillator, in places where you expect to see an aggregate of people, in the airport, airplanes, and so forth. So early defibrillation by first responder is essential. Once the emergency medical system arrives with the rescue team, continue the process, high-quality CPR, and take into the hospital where some interventions can be provided. Basically, the ability to take the patient to the cath lab if there is suspicion of an acute myocardial infarction has been shown to improve outcome. There's discussion about hypothermia. I'm going to address that in a minute. And it's very important the patient be treated in a place in which you have doctors who are dedicated and nurses who are dedicated to the care of a very critically ill patient. So when everything works well, we can have survival outcome up to 20-25%. And when it doesn't work, one link that doesn't work will bring that survival down dramatically. So the saying is that the chain of survival is as strong as its weakest link is a totally valid one, and give us an opportunity to know how to intervene. So what's new? One is very interesting, is the idea to engage the public more effectively in the treatment of cardiac arrest. And there's a foundation that developed the concept that you could be activated, you as a citizen, using an app that you can download, can enroll yourself and make yourself available. So there's a cardiac arrest in some location in which the system is operational. You can be called to help. You can be informed there's a cardiac arrest a couple of blocks from you, and that AED is in a given location, so that the bystander CPR can be started as early as possible as the ambulance arrives. So that's something new that is being encouraged by the guidelines of 2015. Mobile phone dispatch of layperson. In fact, that was shown already in a study published in the New England Journal of Medicine to be effective. Now, very important is to remember the relationship between survival and how soon we're able to defibrillate. I wanted to show you this data here that support that concept. This was a study that was done several years back by Dr. Valenzuela in the casinos of Nevada. They convinced the owners of the casinos to have AEDs everywhere, and because when people are gambling, they're being monitored, it was easy for security guard to identify a collapse of a person who was in the casino, and as soon as they happened, they would activate the security system to bring the AED. It turns out that if there was ventricular fibrillation, and if the person received an electrical shock within less than 3 minutes, survival was 74%. So I tell my resident, that's the best place to have a cardiac arrest, in a casino. And because you can be resuscitated so quickly, probably you're not going to end with any kind of brain injury. You might even wake up and continue to gamble right away. So, yeah. This is what the new guidelines recommend in terms of the way to deliver a shock. I might not really spend much time here because of time constraint, but it's important, the concept that early defibrillation works. And in terms of energy, you have to go with the manufacturer. There was a time in which we were very concerned about the toxicity associated with energy of the defibrillator shock. That was when we used monophasic waveforms. Any manufacturer today uses biphasic waveforms, and for the same level of energy, the cardiac toxicity is much less. So there's less fear of causing injury, therefore the encouragement to deliver a shock as soon as a shockable rhythm is being recognized. Now, another important concept that I want to emphasize, the idea of the bystander providing CPR, meaning chest compression. This is a review of the literature several years back. I think that was for 2010, actually. And there was a discussion whether or not to do rescue breath, mouth-to-mouth ventilation. And what you see there in that red block is what happens in terms of survival when nobody does CPR. And you can see that survival is very, very low. The numbers go from, I can see here, 2%. But if CPR is done, with or without rescue breath, survival goes up immediately. This kind of data was the data that propelled the concept of hands-only CPR, meaning that if you have somebody who is in cardiac arrest and you witness the event, especially in an adult, the presumption that that's a cardiac event primarily and there's enough oxygen for a while, so you don't need to worry about rescue breath, is totally legitimate, and you can concentrate on doing high-quality CPR. Now, if we talk about CPR, I wanted to go back to the physiology for a few minutes because I think it's very important to understand what is that we're doing when we compress the chest. Again, the most important thing that we can do immediately is to ensure that we have a high coronary perfusion pressure, because that is the determinant of cardiac resuscitation. We need to bring oxygen to the heart that is in desperate need of oxygen. So the higher the coronary perfusion pressure, the more likely is that we are going to be able to successfully resuscitate. Now, the coronary perfusion pressure during cardiac arrest occurs in between compression, not when you press on the chest, when you let go. When you press the chest, all the pressure goes up, so there's no gradient for coronary blood flow. So when you go down, when you let the chest re-expand. And the pressure is, like anything else, a function of flow and resistance. The flow is the one that we generate by chest compression. The resistance is the one that we can enhance when we give a vasopressor agent. So we need to concentrate on good CPR. And the basic for good CPR, now that got distorted. I wanted to show you the optimal depth that has been, I think, fairly established based on data in the literature between 5 and 6 centimeters. Now, how do we assess that? I don't know. Don't ask me that question, but that's what you have to do. I'm going to tell you that so depth generates flow, and flow will manifest into coronary perfusion pressure. And the higher the coronary perfusion pressure, the more likely the person is going to be successfully resuscitated. So this is the data that was published back in 1990 by Dr. Paradis, showing this is a patient who had out-of-hospital cardiac arrest. They were unable to resuscitate, were brought to the emergency department, they put lines, and they measured the coronary perfusion pressure. You can see that the coronary perfusion pressure needed to be more than 15 millimeters of mercury for resuscitation to occur. So again, emphasizing that it's true, we need to maintain a good coronary perfusion pressure. So what does it mean, high-quality CPR that would lead to that? Essentially means good depth of compression between 5 and 6 centimeters, a rate between 100 and 120. Avoid leaning. You need to let the chest fully re-expand. If you lean there, you're going to restrict venous return. If the pauses for breathing should be less than 10 seconds, and the moment you establish an airway, we make it very simple. You deliver 1 breath every 6 seconds, meaning 10 breaths per minute. And we can discuss the rationale for that at any time. It's important to avoid pauses so that the time that we're doing the compression should be at least 60% of the time. We don't want to go in sequence. We want to bring the team and do what's called a choreographic approach. Now, because of time, I'm going to tell you some certain things. If we have an arterial line, monitor the coronary perfusion pressure. You want to have an aortic diastolic pressure of at least 25 millimeters of mercury to secure. And if we have a line, that's the way to monitor and decide when to give a vasopressor agent. End-tidal CO2 is very important because it will tell you about flow. End-tidal CO2 essentially is a function of CO2 production, CO2 transport, dead space ventilation, and ventilation. So if everything is constant, during CPR, the amount of end-tidal CO2 becomes a function of the cardiac output being generated. The higher the entitled CO2, the higher the likelihood of resuscitation. So you can look at that. If it's very low, it will help you to make the decision when to stop performing CPR. The other importance of capnography is that it will tell you that the endotracheal tube is in the trachea, and that is the most reliable way of ensuring the tube ends in the trachea and stays there during transport. So very strongly recommended that we use capnography to monitor the proper placement of endotracheal tube. Vasopressor, this is simple. The only vasopressor agent remaining alive is epinephrine. Even vasopressin was kicked out. And epinephrine, I tell you, is in life support because it's true that might increase ROS, but there's no evidence that survival is improved. So epinephrine, and we don't know for how long. Antiarrhythmic for shock refractory VF and VT. You can use lidocaine if you want to. There's new studies showing no big difference between amiodarone or lidocaine. Mechanical compression, we covered that, I think, earlier for the talk about the Lucas 3. All what was said is a valid point. It gives you stability, consistency. You can take the patient in an ambulance and even take it to the cath lab with a device. So I think devices are good. We have talked about extracorporeal circulation. It's a great way of maintaining circulation. And in patients who have not been successfully resuscitated may have a chance through extracorporeal circulation. So I think it's a good option to have. Taken to the cath lab for people who have a coronary occlusion, also improve survival. And in terms of hypothermia, the whole concept, I think, is being revised because there's no difference between 33 and 36 degrees centigrade. So the effort has been moved. We don't call it hypothermia anymore. We call it targeted temperature management. And you choose any number, but stick to that and avoid hyperthermia. We believe that hyperthermia is detrimental, so we need to avoid that. One more comment, prognostication. Let's give yourself time. You don't want to negatively prognosticate before 3 days of a patient that has recovered the body temperature. We tend to remove support early on. I just learned that that will not happen here in Kuwait. Family will want you to keep, so it's better to delay the neuroprognostication for at least 3 days before after the cardiac arrest and after the body temperature has returned to normal. So I think I'm running out of time, so I'm going to give you the summary. Very important to have the concept of chain of survival, engage the community. We need to increase the percentage of patients who receive bystander CPR. AEDs, very important. Today, too few victims receive bystander CPR. We have to increase that. Promote high-quality CPR, very important. The devices, feedback and train people to perform high-quality CPR. And the post-care is very important. In a good ICU, you're going to be managing the temperature somehow, making a decision whether or not to take the patient to the cath lab early on, and of course, care of everything that needs to be cared for a patient who is critically ill.